Hello, everyone, and welcome to Patients Rising University's webinar, our Lunch and Learn series. We're going to get started in approximately 1 minute, so please stand by. Okay, everyone, we're going to go ahead and get started. Welcome to Patients Rising University. This is our Lunch and Learn series. Today, we're going to be doing an introduction to ICER 101, ICER, the Institute for Clinical and Economic Review, and their upcoming review of arthritis treatments. For those of you who are not familiar with Patients Rising, we are a national nonprofit organization dedicated to providing support, education, and resources to people living with chronic and life-threatening illnesses. We work with patients to advocate for access to treatments, innovations, and care that they need. Today, we are going to introduce you to, just like I said, the Institute for Clinical Economic Review. Throughout this webinar, we will call them ICER, and their upcoming review. We are joined today by Paul Langley. Dr. Langley is a professional economist. His undergraduate training was in the UK at the University of Hull, with postgraduate training in Canada at Carleton University and Queen's University. Dr. Langley has taught in the UK and in Australia, with visiting appointments at Carleton University, the University of Ohio, and the University of California. He is presently working with Patients Rising as the Director of Research for the Institute for Patient Access and Affordability. Anna Lagasse. Anna is an athlete, patient advocate, and strategy manager living in Boston. She was diagnosed with systemic juvenile idiopathic arthritis 25 years ago at the age of 11, and today she lives with rheumatoid arthritis and recurrent pericarditis. She is on the Massachusetts Leadership Board of the Arthritis Foundation and also serves on the Foundation's National Advocacy Committee. She is a member of the Tufts Medical Center Patient and Family Advisory Council and serves on the Tufts Quality of Care Committee, where she is also a patient and employee. Anna is on the Patient Advisory Board of Clara Health and consults with healthcare startups, pharmaceutical companies, and other healthcare organizations, collaborating to incorporate the patient voice into healthcare design, technology, and policy reform. Anna is joining us today not only as an arthritis patient, but as someone who is engaged with ICER and recognizes the importance of this patient engagement in their process. This is me. My name is Terry Wilcox. I'm the co-founder and executive director of Patients Rising and Patients Rising Now. And we have been holding ICER accountable since 2016. We have followed their trajectory since that time, and we have evolved in our process. Now I'll give you a little bit of an introduction to ICER. This is Steve Pearson over here. He is the founder of ICER. And I put these other folks over here mainly, I don't like to talk a lot about funding, but ICER has been around since 2006. And they were just sort of going along as an organization, and they had an influx of funding from one specific foundation, which is the John and Laura Arnold Foundation, of $19.1 million between 2015 and 2017. And that does a great deal to give an organization a lot of clout. And part of the reason that we talk a little bit about this is they are sort of at the forefront of this value assessment process. And I think it's important to look at, just to know this. It's just a, hey, FYI, because the John and Laura Arnold are leading a lot of the drug pricing conversation in this country. So we will start with a little bit of feedback. Sorry about that, guys. So here we will move on. First, Paul and I are going to talk about the quality, which is one of the things that we want to make sure that we introduce you to here from the very beginning, to just talk a little bit about this. Now, as an advocate, I've sort of had an evolution around the quality. when we first started our critiques of ICER, it was like, oh, the quality, get rid of, the quality is terrible. Don't use the quality, don't use the quality. And we've had somewhat of an evolution in this. And I kind of, and we're on here today not to have an 11 slide, a bashing of the quality, but just sort of talk about ICER's use of it and how we want to hold it accountable and want to talk about how they use it as opposed to how it could be used appropriately, et cetera. So Paul, can you just kind of give us a really quick, simple overview of qualities? Because it's not just one quality, which is how I used to think about it, but there's many qualities, and sort of how we should think about it.
Thank you, Terry. Yes, this is Paul Langley. Quality adjusted life years is composed of, first, an estimate of the utility that people gain from their current health status, and also an estimate of the length of time they're spending in a particular health state. The notion of quality of life, as opposed to the measurement of qualities, has been around for 40, 50 years, and it's used widely in clinical practice, and we can have no objection to people arguing that their quality of life has improved as a result of a new therapy. What we can object to is how people are actually measuring and making claims in terms of quality of life. And this is where we part company with ICER. ICER gives the impression that there is a single standard quality. Everybody agrees on a particular measure. As Terry has just said, there are a variety of measures of quality of life. They can be broadly broken down into generic measures, which are intended to apply across and make comparisons between disease states. And there are disease-specific measures of quality of life. ICER focuses on the generic measure, which is not intended to capture the quality of life of people in, say, arthritis or particular stages of the progression of arthritis, but it's intended just to give a broad brush image, if you like, of people's health status with arthritis and possibly a range of other comorbid states. This is fine if you're doing a national health survey. It's not good if you're trying to make claims about therapies within the arthritis area. I think this is the important point to make, that ICER is actually giving a false impression of the quality of life through its selective choice of a quality measure, a selective choice in its case of the EQ5D instrument. Terry, back to you.
Yes, I just switched the slide because I thought it was a good segue into what you often talk about, which is the imaginary worlds. And some people, when they first hear you say imaginary worlds, are like, oh, what is that? What are you saying? Is that scientific? Or can you say that more? And I think you have a really good point on this. And so I'd really like you to explain what you mean by their imaginary worlds. And
certainly. I first started writing commentaries and critiques on ICER some 3 years ago. And in the period since then, I've written about 30 of them, and they appear in a journal called Innovations in Pharmacy, and they're free to download. When I talk about an imaginary world, I mean a construct similar to Narnia or to Harry Potter. And this is essentially what ICER is doing. If you look carefully at ICER's framework, what they are asking you to believe is that they could make projections over the next 10, 20, 30, or 40 years and come up with value claims based upon a series of assumptions as to how patients are expected to respond to therapy for a hypothetical patient population tracked over that time interval. This is quite clearly nonsense, because the key point in the scientific method is the construction of empirically verifiable theories and hypotheses. So empirical testability is the one major characteristic that distinguishes science from what we might call pseudoscience. And this is the hallmark of the ICER modeling. One imaginary world is created after another for different disease states. And if you look at the recent reports on JAK inhibitors, you'll see how flexible it can be in generating different worlds. The first ICER draft evidence report on JAK inhibitors was withdrawn within 3 days. They hurriedly changed their assumptions. Another imaginary world was created, which went for 1 year instead of the lifetime of the hypothetical cohort. Depends on what you want to believe. If you believe one set of assumptions, you get one imaginary world. If you believe in another set of assumptions, you get a completely different imaginary world, which may contradict the first. Terry, back to you.
Yes, now I'm gonna talk a little bit about what you just said, science versus pseudoscience. I think this is also important because you're looking at, because you often say, even though as advocates here in the States, we often say, oh, we don't want NICE, we don't want these, European constructs, but you have educated me in a way that's like, no, they actually have a scientific method in place. You may or may not agree with them, but there is a standard that they have that ICER does not even come close to.
Yes, let's pick up on that. When we talk about the difference between pseudoscience and science, it's like talking about the difference between intelligent design and natural selection, right? And only have to look at the report of the Dover School Board to see what is involved in intelligent design and why we would label it as pseudoscientific. The key point, as I've made, the key point to make is that if you want to make scientific claims, then they have to be evaluable. They have to be credible, they have to be evaluable, and they have to be replicable. That means that you should be able to develop claims based upon an underlying theory or model, which you can then take and apply to real world data. The object of the exercise is not to actually prove that your theory is correct, but to demonstrate that it is reasonable, it hasn't yet been falsified. And this means you have to be very careful that you only generate theories or hypotheses which are empirically sustainable. Okay? ICER doesn't do this. None of the ICER claims for cost per quality are in any way, shape, or form evaluable. They are constructs, and ICER's claims are simply a series of assumption-driven constructs. On that basis, they should be labeled as pseudoscience. They can't be falsified. They unfortunately are taken at face value, the reason being that few people look behind ICER's value statements. If you look at the press releases and the blogs that accompany ICER's final evidence reports and that ridiculous voting procedure that they go through at their meetings, that nobody goes behind this and asks the question, well, what's driving this? What assumptions are being made? Are these claims actually verifiable? No, they're not. People take them at face value, and it's only when you dig behind the ICER model you realize that they've essentially created an imaginary construct to drive a particular view on pricing and access to pharmaceuticals.
Okay. And here, ICER loves to talk about the quality or qualities in general as the gold standard in drug pricing. And we know that qualities, like I said just recently, that they're used by other institutions, by NICE. And you have said it, even, and like I said, even though we may not agree with NICE, their use of the quality is a scientific construct.
Yes. Yeah, let me just pick up on that.
Okay.
Outside of the United States, we have single-payer health systems. And if you have a single-payer health system, as in the UK or France, Germany, Australia, then the decision on the criteria by which they will evaluate competing therapies is theirs to determine. NICE in the UK, the National Institute for Care and Health Excellence, has established a criteria called a reference case where it asked manufacturers to make a submission utilizing a series of assumptions and models and projecting forward. This is similar to the ICER approach, but the difference is that this is mandated by a single payer health system. The model is submitted by the manufacturer. It is then passed over to a third-party assessor. The third-party assessor can agree, modify, or reject, and this then goes back to NICE, and a decision is finally made on the actual pricing of the product. In the case of ICER, they are essentially judge, jury, and executioner. They set the standards, they develop an in-house model. It is not transparently reviewed by a third party, as it is in the UK. And so you end up, at the end of the day, with ICER assuming that its criteria are applicable to the United States. So I think it's important to draw a distinction then between standards which are mandated by a single payer health system and standards which are proposed by an arbiter such as ICER, where there is no requirement in the US for this, and in fact under the Affordable Care Act you are not allowed, as far as Medicare and Medicaid are concerned, to make any judgments for the acceptance and pricing of pharmaceuticals utilizing QALYs. So for at least 50% of the US healthcare market, the ICER model, the ICER approach is irrelevant. So there's no such thing as a gold standard. If ICER says that, they're just not being accurate. You decide what the standard is that you want to apply as a healthcare decision maker. You don't simply go and assume that ICER has something relevant to say. Terry?
Yes, I understand. That was a fantastic explanation. Anna, I'm gonna head over to you now and just talk a little. I want to kind of get your thoughts from the patient perspective on QALYs. And I know you kind of work at Tufts now, so you sort of work in this on a daily basis, and you're a much more knowledgeable than the average advocate. But just kind of talk about your perspective on this.
Thank you, Terry. Yeah, I'll try to stay away from wearing my professional hat too much during this conversation. Really, because of the patient, the biggest issue that I take with the QALY is that as a measure, it's really limited, and it doesn't take into consideration all of the different ways that being on a stable and an effective treatment, whether it's for arthritis or another disease state, how that can benefit not just the patient's health, but really all facets of their life. And oftentimes the lives of their family members and their caregivers as well. So for me, access to the treatment that I'm currently on means that not only am I able to work full time, but it's drastically cut down on the number of sick days that I have to take each year. And it's really, and beyond that, it's helped me to decrease my reliance on opiate pain medication. I've been able to return to exercising at a very high level and maintain a healthy weight, which is of course critical for people with arthritis. And I've also been able to get my blood pressure back down to a healthy range, which previously I actually had high blood pressure as a comorbid condition of my arthritis, which, you know, probably isn't something that people think about as being related to arthritis, but in my case that it was. So having access to this particular treatment not only just addresses, you know, sort of these very limited arthritis-related disease activity measurements and disease activity scores that ICER does use within their methodology, but it also impacts my health on, you know, a much broader level as well. And this is to say nothing, you know, when we do talk about quality of life. It doesn't really reflect any of the other things that I'm able to do as a result of being on, you know, the stable and effective treatment, right? So for me, in my case, that includes traveling. Before this call, I'm looking at a trip going to France and Switzerland this January. I run races. I have 3 little, soon to be 4 little nieces that I'm constantly running after. Hiking with my dog, and just, you know, living a life that's of quality and meaning to me. That's not possible without access to these treatments, and that's something, you know, that really gets lost in this conversation, I think, and especially gets lost in the conversation of the quality as a metric.
So, well, thank you. Let's see if I can. Okay. Sorry about the feedback. Thank you. Thank you very much for that, Anna. I appreciate it. Okay. Somebody, if you're not talking right now, can you go? Let's see. There we go. Okay, maybe that'll help. Okay, so I'm sure many of you are asking on the line how you can, or that are out there that are either listening to this now or going to be watching this in the future, in the coming weeks. How can patients and how should patients get involved? We just kind of gave you a really, high level kind of brief overview of what ICER does, what their reports are, how they are used. Many of them are used by health insurance companies and others as something that they look at to determine whether or not your treatment will be covered or how it's not necessarily, they are not a government body, I guess is what I'm trying to say, at least not yet. But one of the reasons that we do these, let me see. I wonder if it's me. Is it me? I don't think so. Okay. There we go. See if it's me. Anyway, Anna, before we get started, the reason that I had Anna on today, before we continue, the reason that I had Anna on today is that she has spoken in an ICER meeting before, and she has been engaged in this way as a patient advocate. And our goal is to get more of you to do this and for more of you to be involved in this way. And so, Anna, first let's talk a little bit about your story and kind of your evolution as an advocate. I picked these pictures here of Anna being active. She's on the cover of Arthritis today, and there she is with her Senator Elizabeth Warren. So Anna, talk a little bit about that for us.
Sure. Let me talk a little bit about my story with arthritis, because I think it'll help add a lot of context as to why I choose to be as involved as I am today. I was diagnosed with systemic juvenile idiopathic arthritis at age 11, as Terry mentioned at the top of the call. And this really came after 3 years of being in and out of the hospital and doctors' offices with all sorts of these strange, sort of seemingly unrelated symptoms. And it really took 3 years before one of the best teams in the world, because I live in Boston, could put this together. So the systemic part of my disease means that I experience inflammation surrounding my internal organs, and for me, that's manifested in what's known as recurrent pericarditis, which is the inflammation of the sac that surrounds my heart, and is every bit as painful and uncomfortable as it sounds. And so when I was diagnosed with my arthritis, there was very few treatment options available, certainly not the treatments that are in ICER's crosshairs today. And what was available at the time really only treated my symptoms and did nothing to slow the progression of my disease. So my arthritis advanced very aggressively during this time, and just 3 years after my diagnosis, I underwent bilateral hip replacements at age 14. So since then, I've had 6 hip replacements in total, 3 knee surgeries, and a surgery on my wrist, which is a little bit uncommon, where the surgeons actually severed 5 major nerves to essentially cut off the pain pathway between the joint, which is so badly damaged, and my brain, and really just to buy me a little bit of time before having that joint replaced as well. So today, I'm really, really lucky that my disease is relatively managed, all things considered, especially where I'm coming from. And I'm able to live a very full and active life, but it's taken me 10 joint surgeries, more than 30 hospitalizations, and more than 40 different medications, which over the years included some off-label usage as well to get to this point, which is really why I'm so passionate about being here today. I don't want other patients to go through what I've been through over the years in my battle to access the best, most effective treatments.
Thank you very much for that, Anna. Now, as in for the next slide, there are many ways, I want to let all of you know, there are many ways that you can share your story, raise your concerns, and help spread the word about ICER and why they do matter to some extent right now, because like I said at the beginning, they're very well funded. They have a big platform for what they're doing, and why we think, at least in their current state, they should not matter. But it's up to patients and patient engagement to really move that dial. It can't be the pharmaceutical industry. It can't just be patient advocates. It really has to be you. So I'm going to start before we get into the final slide, which is all the actions that you can take, I'm going to start by having Anna share with us her experience of speaking at the ICER meeting, how that came about, how Anna, did you even first hear about ICER? How did this engagement, oh, sorry folks, I'm going to go backwards. How did this engagement start? Thanks.
So, as you mentioned, I've been a volunteer with the Arthritis Foundation for a long time, longer than I care to admit at this point, mostly because it just means I'm getting quite older than I'd care to admit at this point. But I do a lot of work in the advocacy space and on specific legislative issues. And so back in 2017, which is the last time that ICER was reviewing arthritis drugs, the Arthritis Foundation had asked me directly to engage. And so they asked me to attend the ICER meeting and provide my patient testimony at that meeting. And so up until this point, I'd never even heard of ICER. I actually met Terry the night before this meeting at a Patient Rising event and got kind of a crash course that night as well. But, really getting ready for this meeting, they send you all these evidence reports and all of these other materials that Paul mentioned when he was discussing ICER and their methodology. And like many of you, if you have even a peripheral knowledge of ICER, I felt so out of my depth and so unqualified to speak at this meeting. And, I'm saying this as somebody who regularly spends time on Capitol Hill and the Massachusetts State House advocating on healthcare legislation. So if you're feeling intimidated by all of this right now, don't worry, you're not alone. There's a ton of resources that can support you. In my case, myself and the other Arthritis Foundation advocates were given a lot of support in developing our testimony. And for me, I was able to hone in on what I think makes my patient story unique. And that's that I was diagnosed with arthritis in 1994. So before any of these drugs being reviewed existed. And I can really speak from a place of before and after these life-changing medications and how much my life has improved over the years as a result. And so it really didn't matter that I wasn't an expert on the quality or ICER's methodology or anything else. I had my own expertise to lend at this meeting that very few other people in the room, if any, could speak to. What I was able to do and what I would encourage everybody else to do is allow yourself to be vulnerable when you're sharing your story, because whether it's ICER or the Arthritis Foundation or whatever venue in which I'm advocating, patient stories and a patient's willingness to go to a very vulnerable place is always what has the most impact. And so what I talked about that day is how as a child, I spent so much of my time in and out of hospitals, missing school. I would have to use a wheelchair whenever I was on school field trips just to sort of keep up with my friends. And, at that time, my disease state was so poor that I really couldn't have imagined my life as it exists today. Oh, God, I still get choked up when I talk about this because I can very easily be transported back to, my 14-year-old self recovering from bilateral hip replacements thinking, I'm never going to go to college. I'm never going to be able to work full time. I'm never going to date or meet someone and fall in love. I'm never going to be able to travel. I'll probably never live independently. And the only reason that I am able to do any of these things is because of the access that I've had to biologic medications over the years. And so for me, when I engage in ICER, that's really the point that I want to drive home, is that my life as it exists today isn't possible without access to these drugs. And I'm sure that my story, while it's unique in many ways, that this idea of quality of life and all of these things that we're able to do when our disease is well controlled, that's not unique to me. And that has a much broader reach and a much broader impact than just healthcare spending, which is what ICER is focused on. And so I don't think that message can be delivered to them loud enough or often enough.
Thank you. Thank you very much, Anna. And just before I get to the last slide and give you guys all of the deadlines and the ways that you can engage, not only with ICER, but with us, I just wanted to talk a little bit about the folks on this slide. These are all advocates who've been at our ICER events. This is Zoe, she has juvenile arthritis. This is Diane, she has psoriatic arthritis. And this is Nicole, she lives with both osteoporosis and arthritis. They're all fantastic advocates. And I just use their pictures here as people who have engaged in this space. Now we're going to move to the last slide, which I know you got a little sneak at. Now, next Friday is November 8th, and that is a very important deadline that we want to talk about, because that is the deadline where if you want to do either of these two things, the first being if you want to write a comment to ICER, I'm going to see if that'll kind of move on through, whatever that is. Okay. Anyway, next Friday, you can write a comment to ICER. A comment. Olivia's going to put in the chat, and we're also going to have it on the webinar page, a link directly to the ICER page where it talks about how you can engage. Now, there's a lot of writing on that page, but if you look specifically at number 3 and number 4, you will be able to learn how to do 1, write a comment, which is number 3, and 2, register to speak. If you happen to live in and around the Oakland area, or you want to make a trip of it, register to speak, but you have to do it by next Friday at 5 o'clock. Everything is due. They make all their decisions based on that. You can't submit a comment after next Friday that would be public. You cannot ask to speak after next Friday. So that's why it's such a key date, and that's why we try to do these the week before so people can be aware of that. The other thing you can do is share your story with Patients Rising. We have a strong Share Your Story platform. You can become a patient advocate if you're interested in some of these things, like going to your own state house or doing federal advocacy. Please join our patient advocate website, and there's a whole slew of information there that you can learn about. And finally, you can register for our Not Worth Less campaign, which we launched in July, which is our patient-driven campaign around educating on the ICER and the ICER process. So those are 5 very distinct ways, and there's many other ways that you can advocate with your disease-specific organizations and others. So please engage if you are at all interested in doing that, because it's so important. Your stories really do matter. Your engagement really matters. So before we close out here, I'm going to see if any of you have any questions. If you do not, does anyone have any questions? Questions? No questions? Okay. So to finalize, if you do have any questions, you are welcome to email us at askaccess@patientsrising.org. That's askaccess@patientsrising.org. And feel free to reach out. And before we close out, I want to thank Paul and Anna for joining us today. We so appreciate your being here and sharing your perspectives on the ICER process and also sharing your stories. Thank you very, very much.
Thanks for having me, Carrie. Always a pleasure.
Thank you. Thank you very much.
Thank you. Have a great day, everyone.